Thanks very much, Homero, and Anne, Homero's wife, who is the WebEx guru of the family, and to Tanya and the whole team at iFlow. I'm happy to be back for probably what I think of the 6th or 7th WebEx that we've done over the last 6 or 8 months, and just wanted to start with an introduction. Of course, the main event is Greg, who's going to be speaking in just a moment, but I wanted to start with just a thank you for all the support that iFlow has given us in our web video education mission. As Homero mentioned, I founded a company called DocStream Incorporated, and in partnership with the Andrews Institute, we have this beautiful facility that we're broadcasting from tonight here at the Andrews Institute Research and Education Center. So thanks iFlow for having us, and thanks for the Andrews Institute for allowing us to host this program. And thanks, Greg, for being here to speak. I started here with Greg in June, and we've really been hitting the ground running, both clinically and educationally. So as a little promotional piece to add on to what Homero said, we have a preceptorship program through iFlow here. We'd love to have you guys join us sometime if you'd like. Talk to your iFlow reps about coming. And we also have a visiting CME preceptorship soon that we'll be initiating this fall. So without further ado, welcome Dr. Greg Hickman.
Thanks, Brandon. I appreciate you guys having me on here. And I've been here at the Institute for 4 years, and about 4.5 years. And you can see a picture of it probably over my shoulder. And brought Brandon on just a few months ago. We're really we're growing, and we're growing with our education department. But what I'm going to talk tonight about is economics of a continuous peripheral nerve block program. And I'm going to speak about physician economics, the hospital economics, and an ASC. Since we're in an ambulatory surgery center here, it's kind of tough sometimes to get them to understand the benefits and uses of a continuous peripheral nerve block program. And we've been very successful here, and our institution, our administration, and our surgeons are very, very behind us and strong supporters, and they really want us to continue and make this thing continue to grow with our continuous block program. And we're going to talk about physician economics first. And the first thing we'll talk about is ultrasound use. And the Cpt 76942 is the Cpt guide for or Cpt code for ultrasound guidance for needle placement for imaging supervision and interpretation. This Cpt states the following: that the ultrasound guidance requires permanently recorded images of the site to be localized, as well as a documented description of the localization process, either separately or within the report of the procedure for which the guidance is utilized. Breaking that down, the documentation elements, the required documentation to get paid for ultrasound use is the evaluation of the anatomical site, the localization process, and you must obtain permanent images. The documentation requirements: permanently recorded images are maintained in the patient record or in some other archive. You do not need these to be submitted with the claim for billing purposes, but they must be stored as printed images on a tape or some type of electronic medium, so that you can always, if you're audited, you can always pull those out and review them and show them that you did do the procedure with ultrasound. A written report of the ultrasound studies is maintained in the patient records, and we'll talk about that in just a second. How we do our permanently recorded images using a Sony printer that's connected to our ultrasound, and we just print off an image and tape that to the back of our chart. We label the anatomy on the ultrasound screen, and then when it prints off, we've got the anatomy labeled on the print, and that serves as our evaluation of the site and the localization process. Looks something like this. This is just the back of a page that of our little procedure note that the nurse fills out as we're doing the procedure, and it has the needle. You don't have to. We don't usually have the needle in the picture that I put on the back of the sheet to leave on the record. Normally, it's just the anatomy. I mean, we'll describe the anatomy with just little initials, as you can see there, to describe the nerves, maybe the local anesthetic. The front of this sheet looks like this. It's just a simple little procedure note at the top, and at the top there's a line here that you may not be able to read, but it says the surgeon has requested this procedure to be done for post-op pain management. That's, we'll get back to that in a little bit. That's sort of a documentation process that helps you get paid. As far as our written report goes, we have a dictated written report that is actually an operative report. And the Surgery Center bills this as an operative report, and we'll get more into that later, and it's been helpful for our Surgery Center. But you see the procedure performed, indications, and then down in the body where we're describing the procedure, we note that it's done with ultrasound guidance here, and that the injection was also done under, I can't read it because the color's off on mine, but the injection was done under ultrasound guidance. So twice we document that during the description of the note of our procedure that we're using ultrasound guidance. That's just to help document that we used ultrasound, and that'll help you get paid for it. As far as getting paid by insurance carriers, certainly the rules vary by payer. Some may require applications for ultrasound privileges be submitted, but I'm not aware of any anesthesiologists ever having to do this. It doesn't seem to be a problem for us at this time. Do expect to get paid for using the ultrasound machine. In Florida, Medicare generally pays around $34 for use of the ultrasound. As far as there's two components of the bill, there's a professional component and the technical component. The professional component is what the physicians do and what they're going to get paid for. The technical component covers the costs of actually performing the procedure, such as the equipment, the non-physician labor, the nursing staff, and supplies. And these are basically what the hospital is going to bill and get paid for. There are site of service payment rules in which in a facility the physician bills a professional fee by adding a 26 modifier. And the thing about if a physician owns or tries to buy the ultrasound machine and bills for it, they're going to have a lot of difficulty doing this. Most insurance carriers are not going to pay a physician for the equipment, for the ultrasound equipment, even if you own it. Now, if you can negotiate a contract and get insurance carriers to pay you for that use and owning the ultrasound, then you can do that. That's going to be extremely rare and hard to do and not very common. As far as the Cpt code, again, you're going to bill 76942 for the ultrasound use, and then you're going to bill also for the nerve block that you're doing. These should not be bundled together. Medicare does not bundle these, the nerve block and the ultrasound, together, so that you should be able to get paid separately for these. If you're using the ultrasound for vascular access, the Cpt code for that is going to be 76937. In Florida, we're getting paid about $40 to $45 from Blue Cross, or about 120% of Medicare. You should expect to get paid about 100 to 170% of your Medicare rates when you start negotiating your rates with your payers. Commercial payers, if you're lucky enough to have many of those, they might pay your bill charges or 80% of your bill charges as a likely default. Those are not going to be very common, and if you have a lot of those, be sure and email me, and we can talk about the possibility of me joining you if you're getting paid that well. But as far as getting paid for your blocks, getting paid for your regional blocks, you should get paid for doing your regional blocks, whether they're single shots or continuous catheters. It's not a part of the global anesthesia fee and should not be billed that way unless you're using the block solely for your anesthetic. And in our facility and the way we've done it, I've done it for 20 years now, is we've considered our blocks to be part of post-op pain management, and they all have some type of a general anesthetic. When we do our hand cases, we'll do a brachial plexus block, supra, infraclavicular, axillary blocks, but we may not have an endotracheal tube or an LMA, but we're running a propofol drip, and so we'll call that a TIVA, or a general anesthetic from that standpoint, and then our block is going to be for the post-op pain management to get an anesthetic fee and a post-op pain management fee. If a third-party payer for some reason hasn't paid for blocks before, and
quick question.
Yep. Question? Yeah.
Or the opposite. Sometimes, just to step in for a second, sometimes during the WebEx there'll be intermittent bandwidth ups and downs that are internet related, and the webcam tends to be the first thing that suffers when that happens, but the screen share does okay. So to make a long story short, if you exit full screen mode, you should always have a good PowerPoint screen one way or another. Occasionally the webcam will get high quality or low quality. But the safe bet is to go ahead and stick with the exit full screen mode if you start to see pixelation, if you start to see drop in quality. Can we get some feedback from people that if that's fixing the problem? Okay, excuse me for just 1 sec. I'll get it fixed up.
We'll see what we can do to get this fixed here. You want to go take a look?
Steve, you want to exit the?
Where do you want to go?
You want to just go to full screen PowerPoint on the program out? Sorry, guys, just give us a minute and see what's cooking here.
This hasn't changed.
All right, guys, the screen share remains in the original computer. So, sorry, is the ball back to us here? Mm-hmm. Just need to share. Gotcha. We should be sharing our screen now. It didn't get swapped back over. Yeah, we had it at the very beginning, and then we gave up screen control so that the introduction could be given, and then it didn't switch back to it. But give us a little heads up if you've got it back, and we'll go ahead and get back started again. Sorry about that, folks. Gotcha. No problem. I think we're good. I think we're good to go.
Are we okay? Do we need to go back and review any of the slides, or do we just want to continue on from here? Oh, okay. Okay, great. All right, great. Now that's great. We got that fixed. Let's continue on here with getting paid for regional blocks. If for some reason a third-party payer has not been paying for blocks, then what you need to do is show them that blocks work, show them that they save time and money, and they improve patient outcomes. There's plenty of literature to show that they improve patient outcomes. Saving time and money, there's some literature out there. You can do your own study. What happened, like I said, I've been here for 4 years. Prior to that, I spent 19 years in Birmingham, Alabama, and I was in private practice for 15 of those years. And what happened, we started doing interscaling blocks for post-op shoulder pain in 1990. About 10 years ago, Blue Cross of Alabama, which was a major carrier in the state, pretty much the private insurance carrier in the state, and they decided to quit paying us for our interscaling blocks. What I did was did a study. We took about 30 or 40 patients and showed them that with the interscaling blocks, they came out of the recovery room faster, they had less pain in the recovery room, they had less use of narcotics in the recovery room, and patient satisfaction was greatly improved. And so I took that to our state society, and our state society presented the data to Blue Cross of Alabama, and they quickly went back to paying us for the post-op pain management blocks, for interscaling blocks. And so if you prove this is so common now, insurance carriers, you shouldn't have much of a problem. But if you prove it to the insurance carrier, it's really hard, very difficult for them not to approve and pay for these things, because the advantages are well documented. Okay, remember on there, I don't know if you probably didn't see it, but on our procedure note, the very top line, we documented that the surgeon had requested the block for post-op analgesia. Basically, this is the equivalent to medical necessity, and that helps you get paid for your regional blocks too. think I skipped a slide here. As far as performing the block, if at all possible, you want to perform the block outside the OR, whether you do it preoperatively or postoperatively. You want to separate it from your anesthetic and from your surgical procedure to make it a separate procedure. This makes it a little easier to bill and collect for. If you have to do them in the OR and you have no other options, you do not bill for the time. You bill for the block as a separate procedure and not a time-based procedure. You want to start your anesthesia time after the block is done if you're doing it preoperatively. You want to document everything you can. You want to create a template in our dictation notes. They document the type of block, the indication or the diagnosis, and we're going to talk about Icd-9 codes. The document the surgeon requested this for post-op pain management, the description of the procedure, the date, and sign, obviously the physician signs the procedure note, excuse me, where and when the procedure was done, and then of course ultrasound, document your ultrasound usage if you use an ultrasound. You want to bill these as a type 2 service charge. There are specific CPT codes for these blocks, and there's a second code if it's a catheter placement. So you're not going to bill these as time, but you're going to bill these as a flat service fee, and usually you can get paid a flat rate. Now, some places are getting paid or have gotten paid based on units, and if you can do that, that's great. Early on, I heard some places were getting paid 13 units for a continuous catheter, and that would be wonderful, but in Alabama and Florida, I've not been able to pull that one off. But if you can do it, and if you can negotiate that, that's great. You want to unbundle your blocks from your anesthesia fee. You do this by adding modifier 59 to your 5-block CPT code. If you're doing bilateral procedures, you're going to add modifier 50. And if you're doing multiple blocks on the same extremity, you're doing a femoral anesthetic block for a total knee, or you're doing a popliteal block and a saphenous block for a foot and ankle procedure, then you get paid for both those by adding a 51 modifier. If you're doing these patients in the hospital and you're making rounds, then you want to bill your daily management fee just like you would if you had an epidural and you're making rounds on those, or a PCA patient you're making rounds. That CPT code is 01996. The Icd-9 codes are the diagnosis codes that you want to use, and you want to use just pain. Not a surgical diagnosis such as a rotator cuff or a labral tear. You just want to use shoulder pain. And here's some of the Icd-9 codes that you can use for different pain in different areas for your post-op pain management. Other acute post-op pain is 338.18. As far as negotiating contracts, make sure that they're unbundled and you negotiate appropriate and separate payment for all your services, for anesthesia, for continuous catheters, or single shot blocks. Unfortunately, you're going to start probably negotiate your rates based on the Medicare rates because that's the standard that everyone knows. That's the standard that everyone starts from. And I know that's not where you want to start because they are so low for anesthesia, but that's kind of what we have to go on. You want to get at least 50% of Medicare rate for your private payer rates, much more if you can possibly get it. And remember, the key when negotiating your contracts, you don't necessarily get what you deserve, you just get what you negotiate. And there's some folks up in Colorado that are getting $300 or more just for using ultrasound for regional anesthetic blocks. As you saw, we're getting like $40. But they negotiated their contracts and they did a good job, and you get what you negotiate. Your EOB or your explanation of benefits details what you get paid for. You want to read this very carefully, or make sure someone in your billing office is reading this very carefully, and make sure that you get paid according to that contract. If you get denied without any kind of an explanation, make sure that denial is appealed, and appeal it over if you have to, because you should get paid, and they should if you appeal it, and you have a contract and you're supposed to get paid for these, they will pay you. Now, to look at some certain CPT codes and get a little bit of understanding of how we get reimbursed, I obviously can't tell you what we get paid by each insurer, but I'm going to show you guys some numbers, some general numbers. I think they're low. These over here aren't too bad. This insurance company's not too bad, but as a general rule, we don't get paid very well in Florida. And what my billing office do every year or every other year when we renegotiate, I say, I want you to, really push hard on renegotiating these block rates. And they don't push as hard because they say, listen, if we can get a couple or three more extra dollars on your anesthesia rate, then we're going to do that, because every case you do has an anesthesia bill, but only about 60% of our patients are getting blocks. And so we kind of go with that, and so these numbers are a little bit low. One thing we found interesting, as you can see, there's a Icd block, which is 64448 or 9, I can't tell. And then the Icd catheter is just the next number below, but they're separated in the femoral block, femoral catheter. One thing we noticed just a couple of weeks ago, we bill the TAP and saphenous blocks as a 64450. That's the other code. That's a code that if you don't have a specific CPT code for a block, that's the other one, and that's what we use. And what we noticed is down here with the ilioinguinal and iliohypogastric blocks, these are actually getting paid more by these three, 4 of the 5 than the other code, where in the past when we would do a TAP block for a hernia. Now we realize that we should probably be doing ilioinguinals and iliohypogastric blocks for hernia repairs, because we get a significantly better reimbursement there. So that's just sort of to give you a general rule of some CPTs and reimbursements. Here's the ultrasound down here, $34, $47, $31, $54, and $36. So give you an idea of what we're getting paid for those. As far as hospital economics, and we're talking about an inpatient facility here, they can, as we talked earlier, they get paid the technical fee. Now what they can do, they can line item bill for their supplies and equipment. And what we've seen down in Central Florida, one of the big hospitals down there, is that you divide up the billing, and it seems to work better for them. And so that it comes from different places. They're billing for their pain pumps out of Central Supply. The pharmacy is billing for the medications that go in the pump, whether it's ropivacaine or bupivacaine. And then the OR is billing for the catheter kit and the supplies to place the block. Hospitals, I don't think they can bill for, I'm pretty sure they can't bill for the use of ultrasound either, although they have to notate it on their billing. But they do bill for the procedure. They can also bill for your surgical procedure that you're doing for this patient, and they collect there. So the hospitals can recoup the money very easily for these blocks and these procedures. And what's interesting, this is a recent study done at the Mayo Clinic, the economic implications of a multimodal analgesic regimen and how that affects the economics. What they did at the Mayo, they took minimally invasive total hip and total knee procedures, and they took a multimodal analgesic approach with an emphasis on continuous peripheral nerve blocks, and compared that to just IV PCA. Now, the multimodal approach, these patients got nonsteroidals, they got narcotics, they got acetaminophen, all these around-the-clock routinely, and then a continuous peripheral nerve block. The IV PCA patients, that's all they got. They didn't get any of these adjuvants, and they just got an IV PCA for post-op pain. And what this showed was that there was a significant, if the slide will advance, like significant cost savings with this multimodal approach. $4,500 cost reduction per surgery. The majority of these cost savings were hospital-based. This decreased the stay in the hospital by 2.2 days, which therefore decreased the room and board costs. There's a significant cost savings there. Also, they decreased their medical and surgical supply costs. They also showed that there was a greater benefit in the ASA 3 and 4 patients than there was for the ASA 1 and 2 patients. Another thing that's interesting is this block at the Mayo, they actually do their blocks in the OR. So they're taking up surgical time, but still there was a significant reduction in OR costs. So by even doing the blocks, taking up OR time, they decreased their OR costs on the end of the case by turning over the rooms faster and getting out and getting to the recovery room quicker. Now the hospital outpatient or your ASC economics, and this is where we are. This is our specialty. It's what we've been doing, and we've done a lot of work here, and we've been able to make this something that is successful in our surgery center. In 2009, Medicare came out with these outpatient prospective payment system, and basically what this says is that the hospital outpatient center or an freestanding ambulatory center, they can't get paid for the use of ultrasound or for the pumps or any of this stuff when you're doing a continuous procedure or block. What they do say in the last line here is they can incorporate the costs of the packaged services into the charge for the nerve block procedure. So that's how we came up with the plan to bill this as a separate surgical procedure to recoup the costs for the surgery center. And that's exactly what I said there. We dictate the procedure note with the indication of post-op pain management. Well, this has worked really well for us. And we did this based on these guidelines. Go back. And in 2009, we did extremely well. I generated, and actually I was a solo anesthesiologist in the surgery center at that time, and generated over $1 million of income for the ASC by recouping this reimbursement for the procedure of putting the blocks and the continuous catheters in. Now, unfortunately, in 2010, Medicare stopped paying for this. They were the ones that came up with the rule, the idea, and then they realized that probably wasn't a good idea, and they stopped paying in January of 10. In July of 2010, United Healthcare decided they would follow suit, and they stopped paying. Although last week when I looked at our reimbursements, they are still paying us for brachial plexus and other nerve blocks. Not a whole lot of money there, $328, but that does at least allow us to break even. So now our goal in the ASC is really to break even, and we'll continue to do our continuous blocks even if we don't break even. And the reason is because we know we're giving our patients better care, and they have much greater patient satisfaction. It's now become an expectation of our patients in the ASC. There's been a word of mouth has spread. All our patients come in expecting blocks. They come to see our surgeons expecting blocks. Our surgeons have become very comfortable, and they're very happy with the experiences our patients have had. And so there's a big surgeon expectation for these continuous catheters and better pain relief. We feel like these make our ORs more efficient. We can turn over the rooms faster because we truly try to avoid narcotics, and we feel like that helps our patients wake up faster even from a general anesthetic, and we can turn the room over and get the next case in. That allows us hopefully to get more cases done. We've actually recruited surgeons here from other surgery centers in town because of our regional anesthetic techniques and our continuous catheters. They've also allowed us to do bigger orthopedic cases. We've done cases I never really dreamed would be possible to do in an ambulatory center. Big tibial osteotomies, humerus fractures, very painful, large cases that we're able to do and send patients home with their continuous catheters. And again, our patient PR has worked magic on its own and provided great word of mouth around the community, and even outside of the state. We've had patients come in for surgery based on our blocks. Now here's currently our reimbursement for the ASC. Private insurers or TRICARE, as I said, TRICARE is paying $328 for brachial plexus blocks. We're getting this kind of reimbursement from one insurer, really good reimbursement over here. And so we're doing well enough to at least break even and keep the continuous catheters going. We're actually still generating income, but not like we did in 2009. So why do catheters in the ASC? We want to provide the best analgesia. There's certainly plenty of studies to show that's the case. This meta-analysis looked at 19 articles with 603 patients. It showed that the continuous peripheral nerve blocks gave better analgesia at all catheter locations and at all time periods. Certainly the narcotics provided more nausea and vomiting, sedation, and itching for the patients. And those are the kind of side effects we want to avoid and we can avoid with continuous catheters. There we go. Here's a study done by Brian Alfeld and Kaiser Inikin at the University of Florida. Early on in the days of continuous catheters, they compared them with narcotics and showed they had significantly lower pain scores. Patients slept better with a continuous catheter than with a PCA or narcotics. They decreased their hospital stays, and this is very common to see. You can send a patient home with a continuous catheter, and they decrease their total joint stay from 5 days to an overnight stay. The military has had significant use of continuous catheters and have had some great articles where they've put catheters out in Iraq or in the field and had these patients flown into Germany and had surgery. They continued their catheters and left them in as long as 30 days and flown them back to the U.S. and continued surgical procedures. And that's greatly reduced narcotic needs in our military servicemen and hopefully have better outcomes for them. These continuous catheters have allowed us to do more aggressive cases in the ASC. As you can see, this huge deficit has actually been cleaned out in this in the femur here. And what the surgeon did was took a big, huge bone graft after this cadaver graft and plugged it in right here. Now this is significant pain. This is tremendous pain. And we were able to do this in our ambulatory center, put a femoral catheter in this patient, and he did extremely well. I remember in the hospital in Birmingham when we were just doing cartilage transplants, when we would harvest cartilage, grow it for 6 weeks, bring it back and implant those cartilage grafts and use an epidural analgesia for those. And they did not do well even with the epidurals. And these patients are doing extremely well here with the continuous femoral catheters. Pretty amazing that we can do those kind of things. We can avoid problems with low molecular weight heparins and anticoagulation. I really don't see much need for epidurals anymore, except for maybe in thoracic cases. And I think some on-Q people would even argue you don't need those anymore. You can actually improve your relationship with surgeons and administrators. Our administration is so behind our continuous catheters that they said we will continue doing them even if we are losing money. And the first year we didn't really have a good reimbursement protocol, and we were losing money by doing it. We weren't getting reimbursed, in other words, but the patient satisfaction and surgeon satisfaction was so significant we continued with them and then found a way to get paid. We actually, when we first opened, we had 2 surgeons that were actually investors in another surgery center downtown, and they would come over to our place because of our continuous catheters and the post-op pain management that we would do. And those 2 surgeons are now full-time at our surgery center and actually left the surgery center that they were investors in. And so we've actually helped with our surgeon recruitment with the post-op analgesia and techniques that we've used. Certainly we want to avoid narcotics and the side effects. We've all seen these side effects from patients on narcotics, IV, PCA, epidural narcotics. It doesn't matter. You've seen all these things. One thing that's interesting is the post-op delirium in the elderly. And this article showed that regional catheters can decrease post-op cognitive dysfunction by 58% versus narcotics in the elderly. And these patients have more dysfunction when the pain's not controlled either. And so this is sort of a personal note, a little story I'll tell you, that my mother-in-law a couple years ago had, or about 3 or 4 years ago, had a total knee done in Birmingham, and she woke up the day of surgery and was doing great. The post-op day 1, my wife called me. I was down here in Florida. She called me and said, you know, what are the signs of a stroke? And you know, my mom's freaking out. I said, what's going on? She said she's confused. She wants to climb out of bed. She's wanting to pull her IVs out. And so I said, well, does she not have a femoral catheter? And she asked the nurse, and she said no. And I said, well, she had a femoral block. She had a femoral block the day of surgery, but then post-op day 1, she had a morphine PCA. And I told her, get rid of the PCA, call Dr. Andrews, get rid of the PCA, and just let her hurt. Well, it's a month later, and I'm down in Florida, and she comes in and moves in with us because she never does recuperate well enough to live on her own. Prior to the surgery, she was like 82 years old, living in Birmingham. We just moved her there from Tennessee about 4 years before that, but she lived on her own, drove, took care of herself, totally self-sufficient. But after the surgery, her mental status was she was not able to do that. And so we had her in our house, and I had my dining room was empty because I hadn't moved everything yet, and so we just put a bed on the floor in the dining room, and she stayed there. One weekend morning, I heard her talking on the phone. I wake up and I hear her, and I thought, oh my goodness, who's she talking to? So I go out and I said, who are you talking to, Mimi? And she goes, well, I called 911. I've got to get out of here. And I said, holy cow. So I said, could I talk to the operator? She goes, sure. And I talked to the operator, and she said, well, sir, we have to send the policeman out because she made the call. I said, that's fine. So the policeman shows up. He walks in. He says, ma'am, what seems to be the problem? She goes, well, sir, I need to get out of here. I don't belong here. And he walks in the front door, and he looks out the back door of the house, and he sees this view out the back door, and he goes, well, ma'am, I think I would stay here. It looks pretty nice to me. So just a little humor there, but it is sort of significant when you've had to deal with the postoperative cognitive dysfunction that could potentially be helpful by decreasing narcotics. So other reasons to do catheters in the ASC, if you can do these blocks in the pre-op holding area, this should hopefully give you a faster turnover in your OR. Significantly, you can decrease the adverse drug effects by avoiding narcotics, therefore allowing you faster turnovers in the PACU. We keep data, and I'm going to show you a slide in just a minute, where looking at our narcotic usage, and in the recovery room we've used most months less than 13% of our patients get narcotics in the PACU. Certainly this will increase our efficiency, allowing the ASC to do more cases, hopefully, increasing our volume, therefore increasing the income for the ASC, which makes surgeons happy. Get better physical therapy potential with continuous catheters, and hopefully leading to less fibroadhesions or frozen joints. And also we have the potential with continuous catheters to decrease chronic pain syndromes. Okay. Why do catheters in the ASC? Well, it helps your surgeons sleep better too. That way they don't get that call at 3 in the morning when the block wears off. And they're going to feel better the next day. They can see more patients in the office, and then that'll lead to more surgeries in the ASC. Patient satisfaction is a major factor. Future reimbursement may actually be tied to patient satisfaction, so this could be very important. We actually had a patient, speaking of patient PR, we had a patient from Michigan who came to Florida just to have her shoulder surgery done here because she saw how well her sister did as opposed to her husband up in Michigan. And so we've actually recruited patients here. I'm going to skip a couple of slides here due to time factors. Do we use home health care in our outpatients? We don't on our ACL patients, our shoulders, or unicondylar knees. We do a once daily phone call, and that's actually preferred by patients. This is based on a survey that Ed Mariano did, and he also showed that 98% of patients were comfortable removing their own catheters. As far as our experience here at the Andrews Institute, with our first 4 years of operation, we've done over 14,000 cases and over 5,000 ultrasound-guided peripheral nerve blocks. Over 2,600 of these were continuous catheters that we sent patients home with. Like I said, less than 12% of our patients received narcotics in the PACU. And here's some data. If you can see it, this is our data for 2007. When we opened up the center, we did 400-something blocks, and then in 2010, we did well over 2,000 blocks. and that means about 1,100 continuous catheters in 2010. So you can see the growth from 07, 08, 09, 010, and here's our monthly data down here with the blocks we're doing, and I think it says ultrasound procedures on the bottom. That's just our total number of blocks that we've done. So our growth has been exponential in our first 4 years, and we hope it to continue growing. As long as our surgery load increases, our block load will increase. We'll skip that, and we'll finish up and go right on into a Q&A session if there's any questions.
We greatly appreciate it. I'm going to open it up to questions for the participants. I did receive a couple of chat questions for you, so if you give me 1 second, I'll go back and see if I can unmute a couple of the participants so we can have a Q&A session. Just a moment. Dr. Hickman, Ash has a question.
Oh, hi.
Oh, that's good.
Can you hear
Go
me?
ahead, Dr. Ash.
Okay, hi. Can you hear me?
Yes.
Yes, we can. Go ahead.
Okay. I have 2 questions. The first one is, how are you measuring patient satisfaction and surgeon satisfaction? Because as you mentioned, the future probably depends on the future of reimbursement depends on satisfaction scores. And then my second question is, whose task is it to negotiate reimbursement rates? Who do you assign that to, or who's in charge of that for you guys?
Good questions. The first question, every patient goes home with a survey, and they're encouraged to fill it out and mail it back. And there are specific questions about the anesthesia and the pain management, and asking them how they, if they were satisfied or not, and we ask them for their comments. And not every block works perfectly. Most of them do, and then how you handle those that don't work is critical too, I think, as far as patient satisfaction. We give the patients access to our cell phone numbers. And if I do the block, or if Dr. Winchester does the block, they have our cell phone number. They actually have both of our cell phone numbers. It's on a sheet there, and they can call us 24/7. And because we just feel like it's very important that they have us accessible to them. But we measure our patient satisfaction by that survey, and our administrator keeps that data and logs it. Surgeon satisfaction is we just know because they're always requesting it. I had a new surgeon that came in here, a big name surgeon, orthopedic surgeon from Houston, and he told me, he said, listen, I didn't do blocks where I came from. I had a little problem. He said, but I want you to do that because Dr. Andrews said, let this guy do his thing and he'll take care of you. And so it's just a reputation that's taken time to develop, but it builds, and now our surgeons would really be unhappy if we weren't doing the blocks.
It's incredible how supportive the surgeons are for the regional anesthesia program here. Just to give you a little anecdote, just yesterday, I had a patient who I spoke to, probably the longest pre-op that I've done all year so far is what I told the surgeon afterwards, because she came in, decided she wanted a single-shot interscaling nerve block for her rotator cuff repair. She had got it in her mind that it wasn't going to be as uncomfortable as had been explained to her, and she was very sort of firmly standing behind that plan. And we talked, and I never try to talk people into anything, but we talked. And I said, I think that all the data, our experiences as well, point towards the catheter being beneficial. And he said, well, no, I think that single shot block sounds pretty good. And ultimately, when the surgeon got wind of the fact that she had elected not to have the nerve block catheter, he came out and said, Winchester, what happened? I said, I promise. I did not. We had a good, strong talk about it, and she really was strongly feeling that she did not want a catheter. And he said, you know what? Let me know next time. He said, we'll tag team the conversation if we have to. I'll scrub out of the case I'm in. Whatever you do, don't let that happen again without the both of us talking to them first. So that was a clear-cut indication of the greater sense of support that we feel at this institution. It's been a real blessing. I came from Duke, where surgeons were quite supportive of regional anesthesia programs too, and it's nice to have that continued support here at Andrews Institute. And I think you'll find the farther along your catheter programs get, the more unified the support network will be from both your administrators as well as your surgeons.
As for your second question, that's an excellent question. If you have a good billing company and you feel comfortable with them and you think they can negotiate for you, then that's basically what I do. If you have a member of your group that's a strong negotiator, is passionate and can speak well, maybe they could help your billing company go when it comes time to negotiate your contracts. It takes somebody, it takes a lot of effort, and you've got to have a billing company that's going to support you, or you or someone in your group needs to do that. That's a tougher question. But that's
Thank you very much.
it.
Here's another question regarding complication rates. In your presentation, you mentioned over 800 or close to 800 continuous brachial plexus blocks. Can you talk a little bit about the complication rates in those brachial plexus catheters?
Yeah, and actually our fellow, we actually, as far as neurologic complications, we've had maybe one, and that was not really related to the block. It was a patient that the sling was too small for them and their hand was falling off, and they actually ended up with a carpal tunnel syndrome. That was one problem we had, we noticed, but just due to the insensate hand, it was falling out and the pressure there. We've had a couple of patients where their hands were not up even, and so they get swelling and edema and some mild carpal tunnel symptoms from that. With the brachial plexus catheters, we really have our biggest complications is early on. Some of them not working, and we've done so many now that our success rate is much higher, and we don't get those calls. Now the big question is pulmonary complications, and the way we do it here is with a posterior approach. Sort of a ultrasound modified Bozart approach, and we use a small volume. I never use more than 15 cc's, and with this posterior approach, we've been very fortunate and not had any significant pulmonary complications. I have had only one patient that had to be admitted after a block because of the block, and that was a patient I shouldn't have blocked in the first place. He was obese, he was overweight, and after the block he just looked horrible. I went and told the surgeon, I said, we can't do this case here, he'll never go home. And while I'm telling that, he had like an 8-beat run of V-TAC, and then he agreed, and we shipped him over to the hospital. And then when he was done at the hospital, they couldn't even extubate him, and he had a tough course, spent a couple days in the ICU. I have early on in this process, in the first couple of years, I had probably 4 or 5 maybe patients that they'd find the day of surgery, and what we do most of the time, we do the block, and they don't even turn their pump on until they go home and go to bed, because they've got that block. I use a 0.5% bupivacaine with epi, so we have a prolonged initial block, and we tell them to start their catheter that night when they go to bed. I've had 3 or 4 patients that the next day had to go to the ER with shortness of breath, and they pulled their catheters, and we realized they got better and realized that catheter placement had caused them to have some phrenic nerve problems the post-op day 1. And now with the way I've adjusted the placement of my catheter, and I haven't had that situation in over 2.5 years. So the complications have been minimal. I think a lot has to do with our approach and catheter placement and volume.
That is an important point, just to reemphasize that point. One of the few things that we see as far as complications, albeit usually mild, unless somebody has underlying lung disease that we're not aware of until the block goes in, and phrenic nerve block suddenly unmasks significant lung disease. Generally speaking, phrenic nerve block seems to be the recurring theme on occasion over the years at Duke, where patients are sicker, and even here on occasion, where you don't realize just how sick their lungs are prior to doing the interscalene block. So I always do a thorough assessment, as does Greg, for COPD. If so, what's the severity index? and be cautious. But I will say that, you know, the data supports this as well as our anecdotal experience, that using a lessened volume, you know, Greg uses, you know, 15 mils of initial injection of a 0.25% bupivacaine solution for the primary block through the interscaling. And a little funny story, when I first got here, I was just routinely, just because that's what I was used to doing, was using 30 cc's of interscaling blocks, because, you know, I probably knew that I could be using less, but 30 was what we always did, right? And all the patients, we get calls about every little Horner syndrome, every phrenic nerve block, everybody in the packet that has any kind of a side effect profile from interscaling blocks. And I realized how much more often I was getting those calls than Greg was getting, so I had to change my technique. I was sick of everybody realizing that his were having less simple side effects than mine. So it really does make a big difference, and I've seen this with my own eyes, to minimize the volume. If you're on the fence about it, you know, minimize it even more. You know, one way to deal with the prospects of having an unexpected phrenic nerve block resulting in significant respiratory depression is to use 10 cc's or less. Use an even lesser duration of action local anesthetic like lidocaine, or even sometimes people advocate chloroprocaine. We don't have it here, but you may have it at your institution. And that way, if you do have a respiratory depression related to the phrenic nerve block, you have a quick response time, a quick recovery, and you can discontinue the catheter after which. But generally speaking, I've been quite impressed here at Duke, and generally speaking, in talking to people out in the field about how infrequently there are really any serious consequences, any consequences of nerve blocks and continuous catheters in particular, as far as the risk profile. It seems very clear to me that in almost all circumstances, the risks are outweighed by the benefits.
Thank you very much. Here's another question related to nerve damage. It seems like it's a hot topic here. Our orthopedic surgeons are concerned with transient nerve damage as well as permanent nerve damage. One of our orthopedic surgeons also states that local anesthetics can cause demyelination of the nerves. Do you have any information on nerve damage, short-term or long-term?
You want to field that first?
Yeah, I'll start with that. Like I didn't finish earlier talking about that. Our fellow that just finished last year looked at 1,000 patients, and what we found that there was a lot of paresthesias that lasted 7 to 10 days. That was very common, and what's interesting is it usually gets better by the time they go back for their first post-op visit. So a lot of people don't realize that. Lasting longer than that is very, very rare, and in our series. And I know Dr. Andrews had one orthopedic surgeon friend of his. He did a shoulder on, and he had just a little paresthesia in his fingertips, in his thumb and index finger, for about 7 days, but it went away, and he was concerned about it. But that's something that we saw fairly regularly in these patients. And the other nerve that's very sensitive is the perineal nerve with our popliteal blocks. When I first started doing popliteal blocks, I was kind of rough on the nerves and would bang them pretty hard because there were articles showing you could inject right in the sciatic nerve and not cause a problem. And when we started collecting our data, we saw that we did have some significant paresthesias lasting sometimes 2, 3, 6 weeks. And so we changed our approach and are very subtle around the nerve and just surround the nerve, the sciatic nerve and the two branches, the tibial and perineal nerves now, instead of really banging on them, and that has completely gone away. We haven't seen that as an issue since that happened. That's sort of our anecdotal experience in looking at our numbers, and I'll let Brandon, he probably will have some literature to back that up.
Generally speaking, I usually don't quote the numbers. You absolutely cannot discount the importance of nerve injury in your patient discussions. It is important to make sure that they're aware that as well as other things are risks. And there's no doubt that there are transient neurologic type symptomatology that can develop after nerve blocks in the short run, on the order of days to sometimes weeks, upwards of 1 to 2% in certain nerve blocks. Of the patients that have prolonged neuropraxia, prolonged injuries, they're almost exclusively sensory is one thing. So as far as effects on your life and morbidity, primarily sensory versus motor. And even among the patients that do get some type of prolonged sensation or motor change, at the 6-month mark, almost all of those patients have made a complete recovery as well. So it's kind of a fraction of a percentage of patients, decimal of a percentage of patients that have a prolonged injury up to 6 months, and then a fraction of a percentage of those patients that actually go on to have a permanent injury. So although it is something important, it's something that every informed consent should include, I don't think under almost any circumstance that risk being so low should outweigh the benefit of a nerve block. And just to take that a step further and talk about, double crush injuries and diabetics and patients with baseline peripheral neuropathy, that's a decision I wouldn't advocate one way or another strongly in my personal practice, and I think I can speak to Greg on this one. Generally speaking, the same patients who have the comorbidities that make you concerned about a theoretical and not proven double crush injury are the same patients that would be harmed by excess narcotic, the same patients that have comorbid cardiac conditions. And so to not do a block because of a theoretical risk when a very clear correlation between pain and narcotic consumption and bad outcomes like cardiac morbidity perioperatively, in the risk-benefit analysis, even in those patients, I tend to think that the nerve blocks outweigh the risks. And so just generally speaking, I mean, I would say that my bias is just that I support regional anesthesia in general, catheters and otherwise, but I think there's good reason to.
And I want to follow up with one more point that from a clinical perspective, before ultrasound, when we were in Alabama, we never blocked a major league pitcher. We did, obviously with Dr. Andrews, we did a lot of professional athletes and have for many years, and we never blocked a professional pitcher or quarterback with an interscalene block. But after I started using ultrasound and I felt comfortable, although the data doesn't prove that there's any significant safety with ultrasound at this point, I feel much safer. And I told Dr. Andrews, and I said, listen, I'll block anybody now, and I have put, well, today I put a continuous interscalene catheter in a major league pitcher that pitched for the Mets and now with the Yankees. And I've done a couple on one NFL quarterback, a couple continuous catheters, and so I routinely doing them on professional quarterbacks and pitchers, interscalene catheters, which we wouldn't have done in the past, but we feel safe. And we're not worried about neurologic. Obviously, we're not worried about neurologic injury. We wouldn't be blocking those guys that have arms and shoulders that are worth millions and millions of dollars.
Greg has even come in and replaced a continuous interscalene catheter that had become dislodged at midnight on an NFL lineman. Talk about going above and beyond the Call of Duty on that one. I was really impressed with that. I got the nose goes on that one. I think Greg drew on that one, but definitely the surgeons who were doing the professional athletes, Dr. Andrews and his colleagues, wouldn't have it in either way. Like Greg said in the past, it was a concern. Careful about intubating. People who sing for a profession, careful about doing nerve blocks, who use their shoulder and their arm for a profession. It's come full circle, and partly due to the safety margin that we've added and experienced, but also I think with ultrasound use as well.
Fantastic. Thank you very much. We do have a question here from Dr. Azam, and I'm going to go ahead and unmute Dr. Azam's microphone. Dr. Azam, your microphone is unmuted. Feel free to ask a question.
Hi, we also have a practice in Florida and a ASC physician-owned setting. It appears that as we make a transition from single shots to catheters, the facility would lose money on the catheters. When you combine the cost of the catheter, the pump, and the ropivacaine. How do we work around that situation? What's your blended rate that you're getting for these catheters?
Well, that's the situation that you have to bill. The facility's not going to bill for the pump. They're not going to be able to bill for the catheter. That's usually, unless they negotiate a specific contract, and there is an ASC locally that is getting paid for the pump specifically. But normally, what you do is they're going to get paid by billing this as a procedure, a separate procedure, and they're going to bundle their costs and basically recoup those by getting paid for billing this as a surgical procedure. That's why we have the surgical op note dictated and on the chart to the coders that our ASC uses actually bill off of our dictation for the continuous catheter placement. So they're recouping that. Unfortunately, Medicare quit paying for it, so that's a loss if you're doing those. If you're an ASC, hopefully you're probably not doing that many Medicare continuous catheters. But the Blues in Florida and United Healthcare and even TRICARE are still paying for those. So you've got to bill it that way because they're not going to be able to recoup the specific charges for the catheter and for the pump and for the drugs. That's a built-in charge. Does that make sense?
As a corollary, is it possible to have home health care deliver the pump filled so you can take out the pharmacy and pump costs?
That's a good question. I would imagine that would be a possible. That's an excellent idea, actually. What we tried one time early on, we tried getting a DME company to provide the pumps, and they couldn't get reimbursed either. So whether a home health care company could get reimbursed or not, I don't know. That might be worth a try to save that cost, and you just do a long-acting block and send them home with their catheter, and it'd be real easy to educate the home health care nurses on how to hook the pump up and turn it on. That's not a bad idea, but I really don't know the answer. It's a good question.
It sounds like there's negotiation is key, as Greg mentioned, and there's going to be times when you're able to to get lucky and negotiate some better rates for various specific procedures, as Greg has. But overall, it sounds like you're in a situation where cost containment, cost savings are probably going to be your best avenue. And of course, in the long run, and this is much harder to analyze specifically, but in the long run, you're going to have an experience like we've had where your ASC is going to become more of a go-to place because word of mouth is going to get out that patients are more comfortable with the procedures that you're doing, that they're going home not having pain emerge at 2 in the morning, but instead 3 or 4 days later. And of course, that'll be a downstream benefit. But in the short run, the here and now, some ways in which you can save money, and this by no means is an advocation on my part as to what types of local anesthetics you should use or what types of equipment. Let me distance myself from that. But generally speaking, the solutions that we use here, the 8% bupivacaine versus the 0.2% ropivacaine, is substantially less expensive. And the primary blocks using 0.5% or 0.25% bupivacaine is substantially less than ropivacaine. I am well versed and well aware of the primarily animal data that supports the safety margin of ropivacaine versus bupivacaine. A meet in the middle acknowledgement of that potential risk versus the potential cost savings and benefit financially is to use less volume. And I think not only does ultrasound give us the benefit of using less volume than in the classic historic landmark-based techniques, but also using a block exclusively for postoperative pain as opposed to for surgical anesthesia. I don't think that you typically need as dense or as high volume of a block. Right. So if you sort of, you meet in the middle, you say, well, maybe we'll use a less expensive local anesthetic and use less volume of it for safety reasons, is one potential approach. As I was analyzing with Dora, our lead block nurse today, there's a number of ways in which you can save money in the way in which you put together your catheter kits as well. For example, and this is, I don't think that you need to take the nerve stimulation out of the equation early on in your ultrasound use, but I think you'll find over time, as I have, that once you get adept with ultrasound, you may not feel like you need a nerve stimulator anymore. And if so, you can save a substantial amount of money using non-stimulating equipment. About $10 to $15 per continuous catheter, and that adds up. We do 1,100 continuous catheters here per year. That's $10,000 to $20,000 in savings right there over the first 12 months if you're able to utilize non-stimulating equipment. Similarly for single shot blocks as well, non-stimulating equipment. But overall, I think you're in a situation where cost savings is the way to go with delayed benefit, as I mentioned, from the standpoint of patient satisfaction and referral base.
I'd love to hear if you get that working with the home health care company. Please give me a shout, email, or a call.
Will do.
Thank you very much. Any more questions for Dr. Hickman and Dr. Winchester? Here's a question regarding more complex knee procedures. We understand you do continuous femoral nerve blocks. What do you do for your subgluteal sciatic in terms of your rates and your percent concentration for the complex knee procedures? I'm sorry.
Well, actually, I don't use subgluteal. I've always used a popliteal block, a high popliteal catheter or a popliteal block. And how we do that in our ASC, with our ACLs, we do a femoral catheter and then we evaluate them in the PACU. And what we've looked at our numbers, we've looked at a couple hundred patients, and what we've come to realize is about 30% of those patients will have sciatic pain, and we'll do just a single shot popliteal, high popliteal block, and gets rid of their pain, whereas 70% do fine with just the femoral catheter. So for my knee procedures, all I really do is a popliteal block, or you can even do a popliteal catheter. That's hard to do preoperatively sometimes because it kind of gets in the way of the surgical prep and area, so we've had a little difficulty with that a couple times. We don't do a lot of sciatic catheters because the single shot duration is so long. If you do a good, strong sciatic block or popliteal block, we've had a nice long duration. Now, Brandon, you may have...
Well, just to comment on that, because of the fact, going back to how we do things here with the bupivacaine block, the duration of action is largely bupivacaine plus epinephrine related. And ultimately, if you're using ropivacaine 0.5% like we were at Duke and like many people are using, I think that's where you step up and feel a greater need for a continuous sciatic catheter in addition to a continuous femoral catheter for complex knee surgery. So going back to the Duke experience, overall the plan, and this is going back to your initial question, what type of approach do you take for the high sciatic blocks and what type of rate do you use for your catheters? What we did in the combination approach with the dual catheters for total knee replacements, for example, is the second nerve block catheter, the sciatic catheter, was almost utilized like a backup plan. A great majority of patients with total knee replacements were having significant posterior knee pain, but their baseline infusion rate was only at 3 cc's per hour. And it was utilized as a rescue bolus. Now, granted, we have a very active acute pain service, had a very active acute pain service as Duke when I was there for the inpatient service. So when patients had the classic posterior aching hamstring-like pain behind their knee, then they would go assess the patient, take a look at the 3 cc's per hour catheter that was around the sciatic nerve, and bolus 10 cc's at 0.2% ropivacaine, and usually rescue the pain almost every time with that. So it's almost like having a trump card in your back pocket. It's not something that you necessarily always need, but when you do need a sciatic block and a sciatic catheter, you need it bad. So having it at a baseline rate, and possibly would be a good time to have a bolus feature if you're sending somebody home. Otherwise, have a lower rate and increase it as necessary when patients have breakthrough posterior pain. So. And going back to the ACLs, just in what you mentioned about the ACLs, it's impressive actually how distal you can go as a rescue sciatic block for ACLs. I always was sort of under the impression that, boy, popliteal is not high enough, that you're going to miss the sciatic branches that pertain to postoperative pain. But we have an internal control group every time we do a rescue sciatic block because they have pain before, and guess what? The pain goes away after we do the sciatic block each and every time. And even further, you don't have that classic posterior identifying pain with an ACL repair to tell you for certain that it's sciatic the way that you do with total knee replacements. When you do a total knee, it's almost always that classic achy posterior hamstring-like pain. ACLs, they hurt top, side, left, right, back, front. They hurt everywhere. But 100% of the time, that pain is getting better when you're doing when you do a rescue popliteal block. So it's interesting that the pain location distribution is quite different postoperatively for sciatic pain for ACLs versus total knee replacements. But both seem to benefit from the addition of the sciatic block.
Thank you for that. Mm-hmm. Here's one of our last questions. What do you tell an administrator that does not see the benefit or economic benefit of continuous nerve blocks?
I would I'd recommend they try having a major joint surgery without one and see how it goes. But
that was a great answer. I love that.
That's a tough question, and obviously different people can be more receptive to what you tell them and listen carefully, and some may just have this blinders on and only going to look at pennies and say there's no way. But if you can really get them to sit down and listen to you and talk about your patient satisfaction, like we talked about, what the future of patient satisfaction could be huge with the future of healthcare. Look at the patient PR, the growth, the ability, all the things we pointed out, the ability to do more cases there, hopefully, and to recruit more surgeons there. If you've got competition and they're not doing it, maybe you can tell that administrator, listen, there are people out there that have already done this. They've been able to convince other surgeons to come there because their patients are getting better care and are happier. And it's a tough sell. I'm not going to say that everybody's administrator is going to listen to you. But then again, also if you've got one of your surgeons that's from the hospital and they've seen the benefit of continuous catheters, some of your strong orthopedic surgeon leaders, maybe they can help you go to that administrator and try to get this across to them. There truly is a benefit, we believe, and we have a strong community agreement here. And unfortunately, it's not that easy for everybody, and I wish I could come out there and help you and just say, come on.
We may not be able to come out there and help you, but you can certainly come to us. That's one of the things I was going to recommend.
That's true too.
Bring them to see us. I think there's nothing more effective in terms of demonstrating the value than to see it firsthand for yourself. And I don't think that there's an institute, and I can speak with confidence in this in all the places that I've visited and programs that I've looked at in regional anesthesia. No place that has a better top-to-bottom structure to their regional anesthesia program, from doctors to nurses to administrators and surgeons, than here. And so bring them to see us. We're talking about all the opportunities to come here. Have them come and witness for themselves the benefit, and not just the benefit the patients are getting, but the culture change that you'll notice when you get here from top to bottom throughout the institution. It's pretty impressive. It's almost palpable in the air how much support everyone has. And I heard one of the administrators last week talking about the surgery she was preparing to have, and she said, "I'll sure as heck know one thing. I ain't doing it without a block." I thought that was funny, that they're well aware of the pros and the cons financially of the nerve blocks, and despite that, they see the very clear, tried and true reason each and every day, and the patients do better comfort-wise.
That's a good point. If you can get your administrator to give our administrator a call or come down. We have people visiting this place all the time. It's kind of a show place, and so we have visitors and folks coming from all over the world to visit and sort of see what we have at this facility. So that's a possibility.
That's a great recommendation. And also, looking over your shoulder, you can see how beautiful the institution is.
It feels like you're walking into a health spa when you drive in. It's amazing.
Yeah, and I'll bring down my group from Minnesota in January to Gulf Breeze. I think it'll be a wonderful place.
Yeah, exactly.
Good,
that's the best time to do it.
Because we're not going to Minnesota in January, so they have to come here.
Sounds like a great plan. Well, Dr. Hickman and Dr. Winchester, I wanted to thank you for a wonderful presentation. I thought it was fabulous. I think the content was outstanding. I look forward to doing another one, perhaps in October or November. Again, the audience, I think, got a lot out of this. So I thank you for your time tonight, and thank you very much. That concludes our presentation.
Thanks very much for having us, guys.
Thank you very much.